What women should know about endometrial cancer. All right, so joining us today are two experts in gynecologic oncology. Dr. Puechl is an assistant professor at Atrium Health Levine Cancer Institute. Her research focuses on endometrial cancers. She's also known for her compassionate, full spectrum care from diagnosis through treatment and survivorship. She's also been recognized by Clemson University for her leadership and impact in education and community health. Also with us is Charmeen Wilkes, who is a physician assistant. She brings nearly a decade of experience in emergency medicine and urgent care and recently transitioned into gynecological oncology, driven by a deep passion for women's health. So let's extend a warm welcome to Dr. Alison Puechl and Charmeen Wilkes.
So I'm so excited to be here today, and thank you for this opportunity. I'm the daughter of a 35-year North Carolina public school teacher, and nothing makes me more excited than educating people on what I'm most passionate about. So Charmeen and I today are going to be talking about what women, and specifically Black women, should know about endometrial cancer. And the first thing I want to highlight is why this really matters right now. And so endometrial cancer, which is a type of uterine cancer, is the most common gynecologic cancer in the United States, and the number of women diagnosed every year continues to go up. This is 4 times more common than cervix cancer, 2 times more common than ovarian cancer, with 62,000 women diagnosed every year. And so that's 1 in 35 women will be diagnosed in their lifetime. So yeah, in general, endometrial cancer has a really favorable prognosis. About 81% of women are still alive 5 years after they're diagnosed. However, and this is what's really important to hear, this favorable prognosis really masks a really enormous racial disparity in endometrial cancer. So I think what I would really like you guys to focus your attention on is this graph here. And so this is the incidence of endometrial cancer from 2000 to 2022. Black women are shown in the green line here, and white and Hispanic women are shown in the pink line. And so you can see over the last 20 years, the cases of endometrial cancer have absolutely skyrocketed in Black women particularly. And then even more concerning is this is the mortality rate. So the rate of death when someone has endometrial cancer. And again, the green line here is going to be our Black patients, and the white line is our white and Hispanic patients. And so to further drive this home, Black women with endometrial cancer have a 55% higher 5-year death rate than their white and their Hispanic counterparts. And this is a bigger racial disparity or bigger racial gap than is seen in colon cancer, than is seen in breast cancer, than is seen in cervix cancer. And this disparity persists no matter the socioeconomic status, no matter the education level, and no matter the insurance status. And so that is why this is important for everyone in this room to listen today about what are things that we can do to address this and what you need to know. So first, we're just going to start with some basic anatomy. And I know this sounds silly, but as someone who sees patients all day long with this, a lot of this is really important, and a lot of times we don't actually fully understand to the way we think we do. So here is the vagina. Here's the cervix. So the cervix is the opening to the uterus or the womb. A lot of people are familiar with pap smears, right? Pap smears screen for cervix cancer. So people will say to me, well, I just had a pap smear. How do I now have endometrial cancer? A pap smear is not screening for endometrial cancer. A pap smear screens for cervix cancer. This is the uterus, okay? So this is the focus of what we're going to be talking about today, also known as the womb. So if you were pregnant with children, that's where the baby is in there. A fallopian tube and an ovary. So remember, ovaries are what make eggs. They make your hormones. The egg is released. It goes down the fallopian tube, and it's fertilized within the uterus, okay? So what we're focusing on today is the uterus, all right? There are 2 important parts to the uterus. So the first witch here, I've kind of highlighted in red for you. That is the endometrium, okay? That is where endometrial cancers come from. That is the inside lining of the uterus, okay? The other part is the myometrium. So that's kind of what I've shown as the in the green here, the thick wall of the uterus. So that's the muscle part that helps to contract out a baby. The muscle part, or the myometrium, is where fibroids arise. A lot of women may have heard of fibroids. These are non-cancerous growths in the wall of the uterus, okay? So these fibroids down at the bottom can be on the outside of the uterus, they can be on the inside of the uterus, they can be in the wall of the uterus, they can be tiny, they can be huge. Fibroids disproportionately affect Black women, okay? A fibroid you don't necessarily have to do anything about unless it's causing symptoms. So this just is kind of Uterus 101 to help us understand what we're talking about today. You can get a cancer of the wall of the uterus, which is a sarcoma. That's not what we're talking about today. We are talking about endometrial cancer, so this inside lining of the uterus. So the endometrium is hormonally responsive. So what does that mean? That means that estrogen is a hormone. Estrogen makes this lining get thick. Or when I'm talking to my patients in the office, I say it's like grass. So estrogen grows the grass. This gets thick, thick, thick when it sees estrogen. Progesterone is another hormone that cuts the grass, okay? So that's what causes someone to have a period, from progesterone. So the ovary is what releases these hormones. The ovary releases estrogen, it grows the grass. The ovary releases progesterone, you have a period. So when women are premenopausal, that is the cycle that someone has a period from, okay? That's the normal response. So anytime when estrogen outweighs progesterone, so meaning there's a lot of grass that's growing and not a lot of something there to cut it. This is the setup for a cancer due to unchecked or unregulated cell growth, okay? So there are a lot of things that can cause this estrogen-progesterone imbalance, one of which is obesity. Our fat tissues make estrogen, and so when the fat tissues make estrogen, this lining gets thicker. Hormone replacement therapy that does not have enough progesterone compared to estrogen. Hormone replacement therapy is great. I'm not saying it's bad, but it has to be in the right dosage. And so if you have too much estrogen, that's going to get too thick. Polycystic ovarian disease, or polycystic ovarian syndrome, PCOS. People may know this. This is something that a lot of premenopausal patients have when they're not having regular periods. So this is a patient that goes 3 to 4 months without having a period. What's happening there? That lining's getting too thick, not having the appropriate shedding. And then there's some more rare ovarian tumors that can produce extra estrogen. So anything producing extra estrogen is problematic for a cancer. So what's the definition of menopause? A lot of times in that office, I'll ask patients, well, when did you go through menopause? And they'll say, well, I've been having hot flashes for 10 years, so I've been in menopause for 10 years. Or I never had hot flashes, so I've never been through menopause. Hot flashes are a symptom of menopause. It's not menopause itself. The definition of menopause is 1 full year without a period, okay? So what causes menopause? Your ovaries stop making progesterone and estrogen, okay? So the average age of menopause in the United States is 51. And what happens when those ovaries stop making estrogen and progesterone, there is nothing to grow the lining of this uterus. So you go from a premenopausal uterus that has a thickened lining to a postmenopausal uterus that should have a very thin lining because there is no estrogen there. Okay, so no lining postmenopausally, lots of lining premenopausally because there's estrogen here and no estrogen over here, okay? Therefore, any amount of postmenopausal bleeding is not normal, okay, in any way, shape, or form. So what I have here are quotes that are said to me in the office. Well, it was just a little bit of light pink discharge, not normal. It only happened one time, not normal. It happens roughly once a month, so I figured I just restarted my period. Definitely not normal. Heavy bleeding that I thought maybe was from life stress, not normal. I thought it was just because I'd started a blood thinner, also not normal. None of these things are normal postmenopausally. So if you have postmenopausal bleeding, spotting, one time, a lot of times, this is endometrial cancer or endometrial precancer until proven otherwise, okay? So what are the next steps? If you or someone you know says they have postmenopausal bleeding, you need to go see your OBGYN, your benign gynecologist, okay? They are going to order a transvaginal ultrasound. So what does this ultrasound do? Is it looks at the uterus. So here's our uterus. And then this right here where the arrows are pointing is the endometrial lining. Okay, so they are going to measure that. And a normal postmenopausal endometrium should be thin, about 4 millimeters or less. And so historically, how we've always managed this is that if the endometrium is greater than 4 millimeters, that endometrium, so this lining, needs to be biopsied or sampled because we got to figure out what's going on in there. There we go. So there are two kind of ways we can do this sampling. The first of which is what we just refer to as an endometrial biopsy or an EMB. So this is done in the office. It's kind of like this straw-like device that we look at the uterus with a speculum. So, you know, that's that uncomfortable metal thing that none of us like, right? We put this straw through the uterus and it kind of sucks out some tissue. This is not the most comfortable procedure. Sometimes we can't get this little straw inside the uterus. And so the other way to get a diagnosis or a sample from inside the uterus is in the operating room for something called a dilation and curettage, or y'all might have heard of a D&C is what it's called. So in the operating room, similar concept, we look at the uterus and then we scrape out the lining of the inside of the uterus in order to get us a diagnosis of what is going on here. Because remember, this is precancer or cancer until proven otherwise. So this is where we're going to take a little sidestep specifically for Black women here, okay? So this was a study published in 2021 in JAMA Oncology. So this is like primo high quality data. The author of this is Dr. Kimmy Dahl, and I will reference her here in a little bit. And so what this study looked at is it said, is an ultrasound actually, or is the 4 millimeter ultrasound cutoff the actual appropriate thing for Black women, or are we underdiagnosing or not finding Black women's endometrial cancers early enough? And what this study found is that if we adhere to that 4 millimeter endometrial lining and only biopsy people who have a 4 millimeter endometrial lining, we are underdiagnosing Black women with endometrial cancer because they often have fibroids, which you can't measure that lining appropriately. And they also oftentimes have more aggressive endometrial cancers that don't have quite that same endometrial thickness, okay? So while the guidelines may say one thing, in my opinion, if you are a Black woman with any amount of vaginal bleeding postmenopausally, whether your endometrial stripe is 2 millimeters or 7 millimeters, you need to have it biopsied so we do not miss something. And this is a very important study that a lot of people do not know about. And then this was just me showing how fibroids, as you can see how a fibroid could impede appropriately measuring what that inside of the uterus would be. So when we get a biopsy back, we get a pathology report back. So there are different types of endometrial cancer. So I often tell my patients, you know, they're flavors of ice cream, they're flavors or types of endometrial cancer, okay? So the pathologist looks at the tissue that was obtained on the biopsy or the D&C under the microscope, and there are about 5 common types of endometrial cancer. These up here are less aggressive. These down here are more aggressive. Thankfully, the most common type in general for everyone, Black and white women, is the least aggressive type, okay? But unfortunately, Black women are more likely to have the more aggressive types than their white and Hispanic counterparts. So after someone gets a cancer diagnosis on a biopsy, that's when they're usually sent to Charmeen and I as gynecologic oncologists, okay? So oftentimes the first question they ask us is, what stage am I? And I cannot tell anyone what stage they are until we operate, because endometrial cancer is staged surgically. And so a stage 1 endometrial cancer is confined to the uterus. A stage 2 endometrial cancer involves the cervix. Stage 3 involves ovaries, vagina, or the lymph nodes in the pelvis. And a stage 4 is elsewhere, like liver, lungs, bowel, somewhere spread outside of the uterus. So for surgery, this is how we kind of approach this. So it's through laparoscopy. So that means small incisions. So you can see up here, I have little instruments that go into the abdomen. We blow up your belly with gas, and then I can operate through watching a video screen there. So the surgery is a total hysterectomy. So total means cervix and uterus. A bilateral salpingo-oophorectomy, which means tubes and ovaries. And then we assess the lymph nodes in the pelvis, and that's through something called a sentinel lymph node technique, where we inject a fluorescent dye into the cervix, and I have a camera that helps to identify the most important lymph node, or the fluorescent lymph node. So this is the surgery that is standard of care for endometrial cancer. One of the things that the research shows us is that Black women oftentimes do not get the standard of care in their surgical management, whether that's being in a rural area or for what reason we're still finding out, but this is the standard of care for every patient with endometrial cancer. And so after surgery, a pathology report is given to me that will tell us what stage someone is and what type of cancer they have. Based on that pathology report, I'm able to make a plan of what is needed. The most common treatment is nothing. Usually, in the most common scenario, is surgery is curative. The next most common is radiation to the top of the vagina is needed. This is very well tolerated. And then in more rare situations, patients need radiation to the entire pelvis, chemo, or immunotherapy. And so this is my last little bit before Charmeen takes over, is resources. So for my Black patients, this is Dr. Kimmy Dahl. I referenced her study earlier. I've never met her personally, but she is very well known in the GYN oncology community. She trained at Chapel Hill and is now at the University of Wisconsin. And her entire GYN oncology career is focused on Black women and endometrial cancer. She has a book coming out. She's a great social media follow, Dr. Kimmy Dahl, with really evidence-based data that is specifically tailored to Black women. And this is a resource I share with a lot of my patients in the office. So I'm gonna let Charmeen take over for our case study.
Good afternoon. My name is Charmeen Wilkes. I am a practicing physician assistant here in Charlotte. Like our moderator explained, I've been practicing a little bit over 10 years, most of that in emergency medicine, but 3 years ago I took the leap and decided to come on to the gynecologic oncology team, and they took me with no experience, and they have trained me up, and endometrial cancer has really been something that I've really kind of dived into with the help of Dr. Puechl and our other oncologists because of how it affects African American women. So I'm really excited to be here today and talk with you about these things because it's really important. It's time to have the hard conversations, the uncomfortable conversations. No one wants to talk about vaginal bleeding, right? That's not something that you're gonna bring up over the dinner table. You need to, okay? Because like she said, it's going to affect African American women a lot more than Hispanic or our white counterparts. So you need to start having the really tough conversations and not being afraid to advocate for yourself when something feels off or wrong. And if someone's not listening to you, if you're not feeling seen, if you're not feeling heard, find someone else to talk to until you are seen, until you are heard. So it's really important to me about patient care and advocacy. So I'm just really excited to be here today to present this interesting case study of where someone was not being seen, was not being heard, and it took us a while to get to her diagnosis before we could actually diagnose and treat her. So I'm from Charlotte. This is my home church, so I'm really excited to be here. So I'll just dive into the case study that you have in front of you. So basically, Mrs. Campbell, she was a 63-year-old African-American female. She presented to her benign GYN oncologist, OBGYN, with complaints of postmenopausal bleeding for over a year, okay? She has a medical history of high blood pressure, which is hypertension, high cholesterol, obesity, and diabetes, type 2 diabetes. She was evaluated 3 different times for the postmenopausal bleeding, okay, by her OBGYN, and was told it was non-cancerous each time, okay? She then decided to go to a different OBGYN, and they immediately said, no, let's stop, let's get an ultrasound and see what's going on. It showed that she had a D-delphic uterus. What that means is she had 2 uterus. So this went undiagnosed, her postmenopausal bleeding went undiagnosed for a year. And when they did the transvaginal ultrasound, she had 2 uterus. So what that means is, right here where I've kind of put a box around it, she had 1 cervix, and coming off of that cervix, she had 2 uterus, what we call a right horn and then a left horn, okay? This is a congenital defect. It is not common, okay? This is just an interesting case, but it's not very common. This is something she was born with and probably did not know she had until she started having the postmenopausal bleeding and then getting the transvaginal ultrasound, which showed it, okay? So what they did, what her OBGYN did, once they saw that she had 2 uteruses, was the right horn had a thickened endometrium and the left horn had a normal appearing endometrium. So remember, we talked about that lining of the endometrium. Less than 4 millimeters is normal for Black women. That may not be the case if you have a history of fibroids, but basically her right horn, so if you think of uterus, your right uterus, your left uterus, was the one that had the cancer. They had been sampling the left uterus at her OBGYN office. So she went undiagnosed for over a year because of this, okay? Because the workup was not done, because the time was not taken to listen to the patient and to get the right answers, okay? So they performed an endometrial biopsy. It demonstrated a grade 1 endometrial cancer in the right horn of the uterus, where the left horn was benign, which is what they had been sampling and giving her that non-cancerous diagnosis. So as Dr. Puechl stated, uterine cancer is surgically staged. It was recommended that she undergo a surgical management with a robotic-assisted total laparoscopic hysterectomy. We took everything out. Uterus, tubes, ovaries, everything gone. And we also did that lymph node assessment as well, okay, to determine if there's any cancer there. So the pathology report we got back basically showed that she was a stage 1A, grade 1 endometrial cancer, okay? So this is a low stage, which is a good thing, okay? Given her low staging and grading of her endometrial cancer, she was basically just dispositioned to surveillance, meaning no chemo, no radiation. Basically, we just followed her. Usually we'll do 3 months, and then go to 6 months, and then go to a year. And then at 5 years, we usually can, I say set you back out into the wild, but we usually can let you go free. You can return back to your OBGYN, your benign OBGYN, after 5 years of normal exams where you're coming to see us for vaginal exams. And after that, if it's 5 years, you're good to go. A lot of patients say, I'm sticking with you. And that's fine. We will continue to see you. They're comfortable with us. We diagnose them. So they stick with us, and we'll just continue to see them for yearly exams, okay? The risk of recurrence is 1 to 2%, meaning it's a very low percentage of recurrence when you're in a low stage, low grade. And like I said, she usually will follow up with a gynecologic oncologist every 6 months for up to 5 years. So takeaways: pay attention to your signs and symptoms, okay? Postmenopausal bleeding is not normal. A little, a lot, once, on a roller coaster, after Christmas, it's not normal, okay? That's something that needs to be worked up, and like Dr. Puechl said, it's cancer until proven otherwise. So if you are having any type of postmenopausal vaginal bleeding, you need to be evaluated. And if someone is not listening to you, or if you're not getting the answers you think you should get, find someone else that will listen. It's so important to advocate for yourself. It's so important to ask the right questions. And if they're not seeing you, if they're not hearing you, we see you. We hear you. We will take care of you. Find the answers that you need to be able to be treated appropriately, and to make sure that we get this percentage for African American women down, because it is glaringly upsetting when I get African American patients into our office that could have been diagnosed early had they come in early, had they paid attention to symptoms early. And not just vaginal bleeding, abdominal pain, abdominal bloating, unintentional weight loss, getting full quickly after you eat. If these things are happening, they can mirror other things, but go in, get evaluated. It may lead to a different diagnosis than what you think is going on, okay? Advocate, advocate, advocate. Find someone who will advocate for you, with you. I always tell my patients, if you're willing to get in the ring and fight, I will get in the ring and fight with you. But we got to show up. We got to show up for ourselves. We have to advocate for ourselves and ask the right questions. Thank you.
Thank you. I know you talked about symptoms for postmenopausal, but what symptoms, or can you get endometriosis, cancer, perimenopausal and premenopausal?
So yes, the answer is you can get endometrial cancer premenopausally and perimenopausally. So premenopausal, if the periods are incredibly heavy and there is not another reason for it, a biopsy should be done. The other thing is I mentioned PCOS, or oftentimes when women will go 3 to 4 months without having a period and then have heavy bleeding. PCOS is a definite risk factor, or not having regular frequent periods is a big time risk factor for endometrial cancer. And then also with obesity or being overweight, that is a risk factor. So that should be more apt to be a biopsy to have tested. So abnormal bleeding, heavy bleeding in the setting of obesity or non-obesity should absolutely get a biopsy.
How often should we be getting our hormone levels checked? And what specifically should we be asking for?
So this is a very in vogue question, like right now with hormone levels. And so in general, if someone's premenopausal, just checking hormone levels is not going to be super helpful for cancer or even really non-cancer symptoms. Hormone levels can help fully identify as someone postmenopausal officially, because your hormone levels will tell that. But if someone's trying to decide on hormone replacement therapy, that's not based on a hormone level, that's based on someone's symptoms. And if you're having symptoms, hot flashes, mental fog, pain with intercourse, things that you feel need to be addressed, it doesn't matter what your labs show, you could still be a candidate for hormone replacement therapy. So hormonal lab checking is not a part of endometrial cancer testing or need at all.
And to just say, it's hard to screen for endometrial or uterine cancer. Like, we can screen and do pap smears for cervical cancer. We can't do that for endometrial cancer. So again, it's why it's so important to pay attention to your symptoms. And if you're having that postmenopausal bleeding, you need an endometrial biopsy to make sure you're not having any signs of cancer.
Thank you.